Very often now people come with investigative reports and scanty history, and one of them that frequently come to our hand is a low TSH or a suppressed TSH. So that by itself is not a diagnosis. It is a clinical crossroad where we have to reach the correct destination. You have to apply other tools as well. Usually the ratio of T3 to T4 is very useful. If an antibody result is there, it's well and good. And look at the interference pattern in certain cases. If the true factor is affected, that is the thyroid is affected and it is hyperthyroidism, it's overproducing, the gland is oversynthesizing the hormones as in Graves' disease driven by thyroid stimulating antibody. The signature is high T3 T4 ratio, more than 20, high radiation uptake and high vascularity on Doppler. If it is a toxic multinodular goiter driven by a somatic mutation in TSH receptor or G protein, the signature is focal hotspots in the iodine scan, often triggered, maybe triggered by a contrast CT or so. And the second one, if it is a broken warehouse where it is thyrotoxicosis due to leak, it is a gland is passive and the preformed hormones are leaking into circulation. The classical example is subacute silent thyroiditis. The signature is low T34 ratio, high thyroglobulin and near zero radio uptake. Do not treat them with methimazole, they won't respond, they need beta blockers or NSAIDs. Now coming to the curious case of amyloid-induced type 2, which is also a destructive thyroiditis. Signature is low vascularity on Doppler, requires steroids. Now it may be an outside source, an exogenous or an ectopic. The hormone is coming from somewhere else other than the neck. Factitious thyrotoxicosis, ingestion of T4. The signature is undetectable thyroglobulin, low radioiodine uptake and low T3-T4 ratio. Next is a struma or still rarer, active synthesis outside the neck, it's in the ovarian stroma. The signature is a low radioiodine uptake in the neck and a high uptake in the pelvis. Then sometimes the metabolic survival switch happens as in CQ thyroid. The axis is suppressed to conserve energy during systemic illness. So the non-thyroidal illness syndrome has a signature of low T3, low T4 in severe cases and high reverse T3. Management, treat the underlying disorders, they recover. And the ghost is what the patient is euthyroid clinically, but the lab has been tricked. Biotin interface is a classical example. The signature is low TSH in sandwich technique and high T4, T3 in a competitive assay. Action is wait for 72 hours for the washout and then redo the investigation. You often get a normal thyroid function test. Both would have corrected because normal kidneys hardly take 6 to 10 hours. The half-life of biotin is 6 to 10 hours and so they wash out from the body. It's only when supraphysiological dose of biotin are taken for cosmetic reasons, for hair growth and as other supplements, over-the-counter supplements, this problem happens. But always check the patient's history of a possible biotin containing tablet. Now, does the patient look sick? If no, think biotin stress. If the thyroid is tender, think of thyroiditis, especially decurrent. If the other orbital signs, then check for TSH receptor antibody. It may be grave. Is thyroglobulin low? If yes, the source is always exogenous. So this is how we should proceed when you get a very suppressed TSH. Thank you.